Usually when we talk about a medical diagnosis, there's this expectation of absolute precision.
Right. It's usually very clean.
Yeah, exactly. It's almost like engineering,
Yeah.
Like if you break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, ah, there it is.
It's entirely binary. I mean, it is either broken or it is not broken.
But then you step into the world of cardiac surgery, and suddenly that x-ray machine is, well, it's useless.
Completely useless.
Right. We're looking at a hemodynamic landscape that is incredibly murky. You have a heart that is simultaneously failing and desperately trying to keep itself alive.
Yeah, and as an anesthesiologist, you are about to intentionally stop it from beating.
Which is terrifying when you think about it. You just hand its entire job over to a plastic circuit and then somehow expect it to wake back up and, I don't know, perform better than it did before.
It is the absolute definition of physiological high-wire walking. You are managing controlled chaos, you're manipulating the very parameters that sustain life, literally minute by minute.
And that controlled chaos is exactly why we're here today. If you're listening to this, well, we know exactly who you are.
We do.
You're an MD anesthesiology resident, and you're specifically preparing for your final exams at Gujarat University. You're staring down the barrel of long-form essays, intense viva voce stations, and complex OSCEs.
The pressure is immense. We've been there.
Exactly. You don't just need some casual summary of cardiac anesthesia. You need the ultimate high-stakes audio study guide.
Right.
So we are going to completely deconstruct the anesthetic management of coronary artery bypass grafting, or CABG.
Right.
But we aren't going to just read you a list of facts from a textbook.
Because rote memorization won't save you in a Viva. I mean, examiners at the MD level, they can spot a memorized list from a mile away.
Oh, absolutely. They see right through it.
What they are actively hunting for, what we are going to build together today, is a profound, unshakable understanding of the underlying cardiac physiology and clinical reasoning.
You need to know the what, sure.
Absolutely, but to secure those perfect 10 to 20 mark answers, you must be able to articulate the why and the how.
So let's start right at the foundation. Part A of our structural roadmap. Before we push a single drug, we have to understand the biological plumbing problem we're trying to solve.
Ischemic heart disease.
Right. The textbooks always talk about supply and demand.
Because that is the inescapable arithmetic of the heart. I mean, ischemic heart disease is primarily a consequence of inadequate coronary perfusion relative to myocardial oxygen demand.
So there's a pre-existing blockage.
Yeah, a fixed atherosclerotic occlusion, and often, superimposed thrombosis or vasospasm. But for your written exams, you can't just say the vessel is narrowed.
You need to be aggressively quantitative.
Exactly. The epicardial branches of the coronary arteries normally have a luminal diameter of about 2 to 4 millimeters.
So mathematically, how tight does that narrowing have to be before the patient actually feels that classic, crushing chest pain?
Well, in the absence of collateral circulation, exertional angina, so pain when the patient is walking or climbing stairs typically occurs when that lumen area is reduced to exactly 1 millimeter.
Wait, down to 1 millimeter.
Yeah. That translates to a 50 to 60% reduction in the diameter of the vessel.
Wow.
But remember your physics. Because area is proportional to the square of the radius, a 50% diameter reduction is actually a 75% reduction in the cross-sectional area.
That's a massive drop in flow. And that's just to feel pain when they are exerting themselves. What about the unstable patient who's, sitting perfectly still in a chair and experiencing crushing angina?
Resting angina indicates a much more precarious state. That occurs when the luminal diameter is reduced down to 0.65 millimeters.
That's practically closed.
It is. It's a 75% reduction in diameter, which equates to a massive 90% reduction in the cross-sectional area. The heart is virtually suffocating even when the body is demanding absolute minimum output.
But here is a detail from the source material that completely changed how I view this disease. We tend to visualize these blockages like a pipe slowly filling up with concrete, right?
Right, like a uniform, rigid, calcified ring.
Exactly. But the data shows that most atherosclerotic lesions are actually eccentric. They sit heavily on just one side of the vessel wall.
Which is a crucial distinction.
So if I'm thinking about the physiology here, if the plaque is only on one side, That means that the rest of the arterial wall doesn't have plaque on it. It's still exposed muscle.
That is a brilliant physiological deduction, and bringing that concept up in Aviva will instantly elevate your score.
Because it's not just a dead pipe.
Exactly. Because the plaque is eccentric, the remainder of the arterial wall is still composed of healthy, reactive, smooth muscle. It is completely responsive to vasoactive stimuli.
Meaning the stenosis isn't static, it's alive.
Yes, it is dynamic stenosis.
Yeah.
The healthy segment of the wall can spasm and contract, drastically altering the luminal diameter moment to moment.
So that explains the unpredictable nature of it.
Exactly. This is why a patient might be perfectly stable 1 minute and in severe ischemic distress the next, without any new plaque rupturing or any change in their heart rate. The healthy wall just clamped down.
That makes the anesthesiologist's job infinitely harder. You aren't just managing a fixed blockage. You're managing a reactive, twitchy blood vessel that could spasm in response to surgical stress or, circulating catecholamines.
It's a very fragile system.
So, knowing how precarious this is, examiners love to ask this. Why do we choose CABG? Why subject the patient to open heart surgery when a cardiologist could just thread a wire up their groin and put a stent in, like a PCI?
You need to have these precise indications locked down for your answers. CABG is generally indicated when PCI is either technically impossible or statistically associated with worse long-term survival.
What's the biggest one?
The primary indication is greater than 50% stenosis of the left main coronary artery.
The Widowmaker. Because if the left main goes down, it takes the left anterior descending and the circumflex with it, right? You lose the entire left ventricle in one shot.
Precisely. Other major indications include severe triple vessel disease, particularly if the patient has concurrent diabetes or an impaired left ventricular ejection fraction.
What if a PCI fails?
CABG is also the definitive treatment for a failed PCI with ongoing intractable ischemia, or when there are life-threatening ventricular arrhythmias originating from a specific ischemic focus that just cannot be ablated.
So we are essentially abandoning the old diseased plumbing and building a completely parallel blood supply.
That's exactly it. It's a mechanical fix.
Which brings us to the surgical reality, Part B. Because before we can anesthetize the patient, we have to deeply understand what the surgeon is actually doing step by step.
Every action the surgeon takes causes a profound physiological reaction that we have to counter.
Right. It all starts with the median sternotomy.
The standard access for an on-pump COBG. The surgeon uses a reciprocating sternal saw to divide the sternum vertically, right down the midline.
But the anesthesiologist isn't just, sitting behind the drapes, checking their phone during this.
Yeah.
There's a very specific, coordinated action you have to take the moment that saw spins up.
Yes. When the surgeon is about to use the saw, you must deliberately deflate the lungs. You either disconnect the patient from the ventilator entirely or hold respiration at end expiration.
Because of the anatomical proximity. Right?
Exactly. The visceral and parietal pleura and the inflated lungs themselves sit directly pushed up against the posterior table of the sternum.
So if they're puffed up?
If the lungs are fully inflated with positive pressure from the ventilator, the saw blade can easily catch the pleural lining, tearing the tissue.
And a pleural tear during positive pressure ventilation instantly creates a tension, pneumothorax.
Right. Intrathoracic pressure skyrockets. Venous return to the right heart drops to 0, and the patient goes into obstructive shock before the chest is even fully open. Deflating the lungs pulls that delicate tissue safely away from the midline.
It's a mechanical detail, but it proves to the examiner that you understand the interface between the surgical field and your anesthetic equipment.
It shows you're paying attention.
So the sternum is open, the retractor goes in. Next, they need the new pipes, conduit harvesting. The two classic choices are the left internal mammary artery, the LIMA, and the saphenous vein graft, the SVG, taken from the patient's leg.
Right.
But the sources are incredibly clear that the LIMA is vastly superior. Physiologically, why is the LIMA the holy grail of bypass grafts?
It comes down to cellular biology and hemodynamics. First, consider the saphenous vein. It is a vein. It is biologically designed to handle low-pressure, slow-moving blood.
Makes sense.
But when a surgeon cuts it out and sews it onto the aorta, it is suddenly subjected to the immense, pulsatile, high-pressure, shear stress of arterial flow. The vein wall undergoes intimal hyperplasia, it thickens, and often fails over time.
But the LIMA is already an artery. It's used to that pressure.
Yes, but it's more than just being an artery. The endothelial cells of the internal mammary artery produce unusually high levels of endogenous nitric oxide and prostacyclin.
Oh, vasodilators.
Exactly. This constant local release of vasodilators and antiplatelet factors makes the LIMA virtually immune to developing atherosclerosis. When a surgeon grafts the LIMA to the left anterior descending artery, that graft stays patent open and functional for decades.
So it actually offers a massive statistically proven survival benefit compared to using only vein grafts?
It's a game changer for the patient's lifespan.
Okay, so they have their conduits ready. The traditional next step is placing the patient on the cardiopulmonary bypass machine, stopping the heart, sewing the grafts on, and then weaning them off the pump.
But examiners will expect you to differentiate the specific types of CABG procedures.
Because the surgical approach dictates the entire anesthetic plan, right?
Broadly, there are three categories you must define. First is standard on-pump CABG, which we just described. The heart is chemically arrested, and the bypass machine breathes and pumps for the patient.
Like stopping a car engine to rebuild it.
Right. Second is off-pump CABG, or OPC-CAB. In this approach, the surgeon operates on the beating, working heart without ever using the bypass machine.
Which is like fixing the engine while the car is speeding down the highway at 80 miles an hour.
That's a great analogy. And the third is minimally invasive CBG, like mid-cab or the robotic T-cab.
So those avoid the big sternal saw entirely.
Correct. Minimally invasive approaches avoid the full median sternotomy. They use small, left-sided thoracotomies or tiny robotic ports to harvest the LIMA and graft it to the LAD.
So it's really a mechanical versus physiological trade-off. On-pump CBG triggers a massive, whole-body inflammatory response from the machine, but it gives the surgeon a perfectly still, bloodless target to sew on.
Well, OPCP spares the body from the inflammation of the machine, but requires the surgeon to perform microsurgery on a wet, violently moving muscle.
And that choice alters everything about how you evaluate the patient beforehand. Which brings us to Part C, preoperative assessment. This is absolutely essential.
You cannot walk into a cardiac OR blind. Your preoperative assessment is arguably the most critical phase of the entire process.
So the goal isn't just to say, yeah, the patient has heart disease.
No, the goal is to define the exact severity, identify their functional limitations, and risk stratify them for the specific physiological insults they are about to face.
Let's start with quantifying the severity of their chest pain. We need standardized language for the exams.
You must use the Canadian Cardiovascular Society, or CCS, grading scale for angina. It is the universal standard.
Break it down for us.
Class 1 is angina occurring only with unusually strenuous exertion. Class 2 is angina with moderate exertion, like walking rapidly uphill or climbing stairs after a meal.
Okay, that's pretty mild.
Then Class 3 is angina with mild exertion, such as walking 1 or 2 level blocks at a normal pace. And Class 4 is the inability to perform any physical activity without discomfort or the presence of angina at rest.
So if a patient is CCS Class 3 or 4, you instantly know their dynamic stenosis is incredibly tight, and your margin for error during induction of anesthesia is practically zero.
Exactly. But for overall perioperative risk, calculating the chances of them having a major adverse cardiac event, the sources hammer home the Lee Revised Cardiac Risk Index, the RCRI.
Oh yeah, this is a guaranteed exam topic. Let's break down the exact predictors.
The Lee RCRI is an elegant, validated tool. It consists of 6 independent clinical predictors. You assign 1 point for each. First, high-risk surgery. This includes intraperitoneal, intrathoracic, or superinguinal vascular procedures.
Well, CABG obviously counts as high-risk intrathoracic.
It certainly does. Second, history of ischemic heart disease, which is evidenced by a prior myocardial infarction, a positive stress test, or pathological Q waves on an ECG.
That makes sense.
Third, history of congestive heart failure, meaning a history of pulmonary edema or a significantly reduced ejection fraction. Fourth, history of cerebrovascular disease, such as a prior stroke or transient ischemic attack.
Let me pause on that fourth one. Why does a history of a stroke matter to the heart? I mean, it's a brain issue.
Because atherosclerosis is a systemic disease. If the carotid arteries or cerebral vessels are diseased enough to cause a stroke, the coronary arteries are guaranteed to be in terrible shape.
Oh, right.
But more specifically for CABG, if they have cerebrovascular disease, they are at an astronomically higher risk of having a massive perioperative stroke when you place them on the non-pulsatile flow of the bypass machine.
Or when the surgeon clamps that calcified aorta,
Right.
sending showers of microemboli up to the brain.
Exactly. What are the last 2 predictors? Fifth, preoperative treatment with insulin for diabetes. And sixth, preoperative serum creatinine greater than 2.0 milligrams per deciliter.
I really want to dig into those last two because examiners love to ask why. Why specifically diabetes managed with insulin, and not just diabetes managed with diet or oral metformin?
Diabetes requiring insulin indicates a much longer duration and a far greater severity of the disease. It implies extensive, irreversible microvascular and macrovascular damage.
But from an anesthetic perspective, what's the big fear?
The most terrifying complication of insulin-dependent diabetes is autonomic neuropathy.
The destruction of the autonomic nervous system.
Exactly. The vagus nerve and sympathetic fibers are damaged. A healthy patient who suddenly loses blood volume will mount a reflex tachycardia to maintain cardiac output.
But a diabetic patient?
A diabetic patient with severe autonomic neuropathy has lost that baroreceptor reflex. If their blood pressure drops during induction, their heart rate simply will not rise to compensate. They just spiral into cardiovascular collapse.
That is terrifying.
Furthermore, they suffer from silent ischemia. They might be actively having a myocardial infarction on the table, but because their effervescent pain fibers are dead, there are no classic physiological signs of distress until the heart simply stops.
Wow. And what about the final criterion, creatinine over 2.0? How does the kidney destroy the heart during a CABG?
It's the cardiorenal axis. Severe renal dysfunction means the patient's intravascular volume status is incredibly fragile. They cannot handle the massive fluid shifts associated with the bypass machine's priming volume.
And electrolytes.
Yes, they are highly prone to life-threatening electrolyte derangements, particularly hyperkalemia, which will cause lethal arrhythmias as you try to wean them off the pump. Moreover, chronic kidney disease patients often have accelerated severe calcification of their aorta.
Okay, so we calculate the RCRI to understand the statistical risk, but the sources keep coming back to a much simpler concept. Functional capacity. It seems like the patient's ability to just do basic daily tasks trumps almost all the fancy scoring systems.
Because functional capacity is the ultimate real-world integrated stress test. It tells you exactly how their heart, lungs, and muscles work together under a load.
We quantify this in metabolic equivalents, or METs, right?
Yes. One MET is the resting baseline oxygen consumption of a 40-year-old man, which is approximately 3.5 milliliters of oxygen per kilogram per minute. For cardiac surgery, the magic threshold you absolutely must know is 4 METs.
Paint a picture for the listener. What does a 4-MET workload look like in everyday life?
It is the ability to walk 1 or 2 blocks on level ground at a normal pace, or to climb a single flight of stairs without having to stop because of chest pain or severe breathlessness.
Just, can you climb a flight of stairs?
Yes, exactly. If a patient can achieve 4 METs without symptoms, their cardiovascular reserve is generally considered robust enough to withstand the immense metabolic stress of surgery, anesthesia, and cardiopulmonary bypass.
And if they can't?
If they cannot hit 4 METs, their risk of perioperative mortality skyrockets, and you must assume their heart is functioning right on the razor's edge of failure.
All right, moving from the clinical history to the physical investigations. We obviously need an ECG, an echocardiogram, and coronary angiography. Let's start with the 12-lead ECG. I have to ask a devil's advocate question here. If we're going to monitor them live in the OR with continuous 5-lead ECGs and real-time computerized ST segment analysis, why do we care so much about an old static piece of paper from their chart taken 2 weeks ago?
Because context is everything in anesthesia.
Yeah.
You are looking for a baseline. Let's say you're in the OR, induction goes smoothly, but suddenly you look at your monitor and see a deep Q wave or a left bundle branch block.
Okay.
Is that a brand new, catastrophic, massive myocardial infarction happening right in front of your eyes? Or is that just what their ECG has looked like for the last 5 years because of an old, fully healed anterior infarct?
Oh, I see.
You cannot identify a new ischemic event without knowing exactly what the old baseline looked like. You must have that preoperative ECG mapped in your mind to compare against intraoperative changes.
Okay, baseline established. Now for the echocardiogram. It gives us a moving picture of the heart. What specific data points are we extracting from that report to build our anesthetic plan?
You are looking at 3 primary parameters. First, the ejection fraction, or EF. Normal is 55 to 70%. An EF under 30 or 40% indicates severe left ventricular systolic dysfunction.
So that tells you instantly that your induction must be incredibly gentle.
Yes. And you will absolutely need inotropic support ready to go when coming off the bypass bump.
What's the second parameter?
Regional wall motion abnormalities, or RWMA. The left ventricle is divided into segments. If the report says the anterior wall is hypokinetic, meaning it's barely moving, it tells you exactly which coronary artery is severely diseased.
In this case, the left anterior descending.
Right. It gives you a geographic map of the ischemia.
And the third.
Valvular assessment. Is there concurrent severe mitral regurgitation or critical aortic stenosis? If there is, the surgeon cannot just do a CABG. They will have to replace a valve as well.
Which dramatically lengthens the cross-claim time.
Exactly. It increases the duration of cardiopulmonary bypass and completely alters your hemodynamic goals for the entire case.
Finally, the coronary angiography. This is the anatomical roadmap, right? It injects dye into the coronary tree to physically show the blockages.
It quantifies the stenosis, tells us if there is left main disease, and shows the surgeon exactly where the healthy tissue is so they know where to land their bypass grafts.
So, we know the patient's history, we know their risk, we know their anatomy. Now they roll into the operating room. Let's talk about monitoring, Part D. This is a very high-yield section for the exams.
It is. Standard monitoring is obvious. Continuous pulse oximetry, capnography to measure end-tidal CO2, and core temperature monitoring, usually via a nasopharyngeal or esophageal probe.
But let's dig into the intraoperative ECG. We don't just throw 3 standard stickers on the chest and call it a day.
Absolutely not. For cardiac surgery, a 5-lead ECG with continuous computerized ST segment analysis is mandatory.
And examiners love to ask which specific leads you watch on the monitor. The gold standard combination is monitoring lid 2 and lid V5 simultaneously. Let's give the deep physiological reason why those 2 specific angles are chosen.
Think about the anatomy of coronary perfusion territories. Lead 2 looks right up the inferior axis of the left ventricle. The inferior wall is typically supplied by the right coronary artery.
And it's good for arrhythmias too, right?
Yes, lead 2 is parallel to the P-wave axis, making it fantastic for diagnosing subtle arrhythmias.
What about V5?
Lead V5, on the other hand, sits directly over the bulk of the anterior and lateral wall of the left ventricle. This massive expanse of muscle is supplied by the left anterior descending artery, the vessel most commonly affected by severe, life-threatening ischemia.
So by dedicating one channel to lead 2 and one channel to V5, you are electronically blanketing the vast majority of the myocardial mass that is at risk of starving. You're watching both the right and left coronary systems simultaneously.
Exactly. Moving to advanced monitoring, an arterial line is absolutely mandatory before induction. You need continuous, beat-to-beat, invasive blood pressure monitoring.
But here is a major clinical trap that examiners will use to test your situational awareness. You don't just blindly pick the right radial artery for your A-line.
Right. You must actively communicate with the surgeon. If the surgeon plans to harvest the radial artery to use as a bypass graft, and you just cannulated it and damaged the endothelium, you just ruined their conduit.
That would be a disaster.
You also avoid a radial artery if the patient's history notes a previous brachial artery cut down on that side, such as from an old cardiac cath, because the scarring alters the pressure waveform.
Furthermore, you need to understand the physics of the chest retractor. Radial arterial lines can give falsely low readings during the specific phase of the surgery when the chest is open.
This is a great point.
Why does that happen? How does opening the chest affect the wrist?
When the surgeon inserts the heavy steel sternal retractor and cranks the chest wide open to harvest the internal mammary artery, the sheer mechanical force can severely compress the subclavian artery between the clavicle and the first rib.
Oh, wow.
This acts like a clamp, artificially dampening the pressure wave traveling down to the radial artery.
So if your radial line suddenly reads 60/40 immediately after the chest is cranked open, do not panic and start pushing massive doses of vasopressors.
First, look at your surgical field. Check the aorta directly, or look at the pressure reading from your central line. You must recognize anatomical artifacts.
Yeah, it is a phenomenal clinical pearl. Now let's wade into the big debate in cardiac monitoring, assessing preload and cardiac output, the central venous pressure line, the pulmonary artery catheter, or PAC, and transesophageal echocardiography, or TE.
Let's break down the historical reliance on the PAC versus the modern supremacy of the T.
Historically, the PAC was the undisputed gold standard, right?
It was. You float the balloon-tipped catheter through the right atrium, the right ventricle, and wedge it into a small branch of the pulmonary artery. This gives you the pulmonary artery occlusion pressure, or PAOP.
Which approximates left ventricular and diastolic pressure.
Right. It's a numerical surrogate for left-sided preload. Normal is 4 to 12 millimeters of mercury. It also allows you to calculate thermodilution cardiac output. For decades, anesthesiologists relied on a sudden rise in PaOP to tell them the heart was getting ischemic and stiff.
But relying on a pressure number to detect ischemia is deeply flawed.
It is deeply flawed because it is an incredibly late and insensitive marker. This is where transesophageal echocardiography completely revolutionized the specialty.
Let's hit them with the statistic from the sources.
The source data provides a staggering statistic. 61% of regional wall motion abnormalities, meaning segments of the heart failing to squeeze properly detected by T, happen entirely without any significant changes in heart rate, systemic blood pressure, or pulmonary artery pressure.
Wait, I want you to really internalize that. More than 60% of the time, a wall of the heart literally stops pumping because it is suffocating, and your blood pressure cuff and your invasive PA catheters show absolutely nothing wrong.
Yes, and to understand why that happens, you must intimately understand the ischemic cascade.
This is the physiological sequence of events that occurs when a coronary artery occludes.
Exactly. The very first thing that happens is a metabolic perfusion defect at the cellular level. Lactic acid builds up.
Okay, step one is metabolic. Then what?
The second thing that happens is diastolic dysfunction. The myocardial cells lose the ATP required to actively uncouple actin and myosin, so the heart muscle becomes stiff and fails to relax properly.
And then?
The third thing that happens is systolic dysfunction. The starved muscle fibers physically lose their ability to contract. This manifests as a regional wall motion abnormality.
Which is exactly what the T is watching in real time.
Exactly. The T sees the wall stop moving instantly at step 3. But what happens next? Only after the wall stops moving do you finally get electrical changes, like ST segment depression on the ECG.
And only after the ECG changes do you finally see catastrophic hemodynamic collapse, which is when your blood pressure drops or your PA catheter pressure spikes because blood is backing up.
So the T is effectively a time machine. It lets you visually diagnose the ischemia at step 3, while the PAC and the standard monitors are blindly waiting for step 5 when the heart is already failing.
That is the physiological justification for why T is the ultimate monitor for myocardial ischemia.
Precisely. Examiners want to hear you articulate that exact ischemic cascade to justify your choice of monitors.
Okay, the patient is fully monitored, A-line is in, T-probe is ready. We are moving to Part E, anesthetic management. Let's start with induction of anesthesia.
We're taking a patient who is awake, anxious, and transitioning them to general anesthesia. The ultimate overarching goal here is maintaining the myocardial oxygen supply and demand balance.
That balance is the central dogma of cardiac anesthesia. So my instinct, playing the role of the junior resident here, is to just knock them out as fast and deep as possible so they don't feel the intense sympathetic stress of a laryngoscope blade going down their throat. I'd want to give them a massive bolus of propofol and be done with it.
And that approach would likely cause immediate cardiovascular collapse on the table.
Really?
Induction in a patient with severe dynamic coronary artery disease must be incredibly slow, deliberate, and fiercely hemodynamically stable. A massive bolus of propofol will cause profound venodilation and arterial dilation.
It crashes their systemic vascular resistance.
It completely ablates their sympathetic tone, crashing their blood pressure.
And if the systemic blood pressure crashes, the aortic root pressure crashes. The coronary arteries branch directly off the aortic root. If there's no pressure pushing blood into those diseased, narrowed vessels, coronary perfusion drops to 0, and you instantly induce massive global ischemia.
Exactly. You must avoid hypotension. But equally, if not more importantly, you must absolutely avoid tachycardia.
Let's explore the math of tachycardia. Why is a fast heart rate the absolute enemy of the ischemic heart?
It is a physiological double whammy. First, the demand side. An increased heart rate linearly increases myocardial oxygen demand. The engine is doing more work per minute, so it burns more oxygen. That's intuitive.
Right. But the second factor.
On the supply side, it's devastating. Unlike every other organ in the body, the coronary arteries perfuse almost entirely during diastole when the heart is relaxed.
Okay, so when the heart rate increases from 60 to 100 beats per minute,
the absolute time spent in systole, the squeezing phase, stays relatively fixed. The heart simply cuts into its diastolic resting time to beat faster.
So tachycardia increases the heart's oxygen demand while simultaneously strangling the very time window it uses to receive its oxygen supply.
Yes. Therefore, the physiological goal of induction is slow, low, and well perfused. Keep the heart rate in the 50s or 60s, and keep the mean arterial blood pressure tightly controlled near their baseline.
How do we achieve that pharmacologically without using massive doses of propofol?
We rely on a balanced technique, heavily utilizing high-dose narcotics. We typically use a small dose of midazolam for amnesia and anxiolysis, combined with a large, titrated dose of a synthetic opioid, classically fentanyl.
Why fentanyl? What makes it better than morphine for this specific patient?
Fentanyl is incredibly cardiostable. Unlike morphine, it does not cause histamine release, which would trigger severe vasodilation and hypotension.
Ah, no histamine.
Right. Fentanyl profoundly boosts the sympathetic nervous system's response to the agonizing stimulus of intubation, keeping the heart rate and blood pressure perfectly flat, but it does so without causing direct myocardial depression. The heart muscle itself continues to squeeze with its normal force.
And a muscle relaxant.
We use a non-depolarizing muscle relaxant like rocuronium or vecuronium to facilitate intubation. The secret is slow titration, giving small aliquots of the drugs and waiting for circulation time to observe the effect, rather than pushing a massive generic milligram per kilogram bolus.
Okay, they are safely asleep and intubated. The surgeon is prepping the chest. How do we maintain that anesthesia for the next 4 hours?
Again, balanced anesthesia. We continue the opioid base, perhaps targeting a total fentanyl dose of 10 to 15 micrograms per kilogram to ensure profound analgesia. But we combine this with a volatile inhaled anesthetic, such as isoflurane, desflurane, or sevoflurane.
Now, I know some people use total intravenous anesthesia, or TIVA, but the sources strongly emphasize the benefits of volatile agents for CABG. What is the cellular benefit of using inhaled gas?
This is a massive concept. It is an exam buzzword. Ischemic preconditioning.
Let's unpack that.
Volatile anesthetics don't just put the brain to sleep. They actively trigger a complex protective cellular cascade within the myocardial cells themselves.
Explain the mechanism. How does breathing a gas protect the heart muscle?
The volatile agents interact with the cell membrane and trigger the opening of ATP-sensitive potassium channels specifically located within the mitochondria of the myocytes.
Okay, so they target the mitochondria.
When these channels open, they slightly depolarize the mitochondria. This incredibly specific action protects the mitochondria from lethal calcium overload and explosive oxidative stress during the periods when the heart is deprived of oxygen, like when the surgeon clamps the aorta, and during the subsequent rush of oxygen during reperfusion.
It's essentially pharmacological armor. By simply running a volatile anesthetic during maintenance, you are proactively training the heart cells to survive the massive intentional ischemic insult of the bypass run.
It literally reduces the final infarct size and preserves postoperative ventricular contractility.
It is brilliant physiology, which brings us inevitably to the beast itself. Part F, cardiopulmonary bypass. This is the absolute core of cardiac anesthesia knowledge. If you are an anesthesiology resident, examiners expect you to know the CPB circuit backwards, forwards, and upside down.
They certainly do. Let's trace the physical journey of a drop of blood as it leaves the patient and travels through the machine.
Right, step one.
First, venous blood must be drained from the patient. The surgeon places a massive venous cannula, usually directly into the right atrium, or they use 2 cannulae, one in the superior vena cava and one in the inferior vena cava, known as bicaval cannulation.
Because venous pressure is incredibly low, this blood relies on gravity or gentle vacuum assistance to drain down into a large plastic venous reservoir.
Right.
So the reservoir is exactly what it sounds like, a holding tank. It gives the perfusionist a buffer of fluid volume to manage shifts in the patient's blood pressure. Where does it go from the tank?
From the bottom of the reservoir, the blood is aggressively pulled by the main arterial pump. Historically, these were roller pumps, but modern circuits often use centrifugal cones.
This pump generates the massive driving force required to push the blood through the rest of the high-resistance circuit.
The blood is pushed directly into the oxygenator.
The artificial lungs. How do they actually work on a physics level? Are we just bubbling oxygen through the blood?
No, bubble oxygenators caused horrific destruction of blood cells and massive emboli. Modern circuits use membrane oxygenators.
How does that look inside?
Inside that plastic cylinder, the blood is forced to flow around tens of thousands of microscopic, porous, hollow fibers. Pure oxygen and medical air are blown through the inside of these hollow fibers.
So the blood and gas never actually mix directly.
Exactly. Gas exchange occurs purely across the microporous membrane via diffusion gradients, oxygenating the hemoglobin and sweeping away the carbon dioxide.
And the temperature control?
Built directly into the oxygenator module is a heat exchanger. It consists of steel or aluminum tubes carrying hot or cold water. As the blood flows past the water tubes, the perfusionist can precisely cool the patient's core temperature down to 28 degrees, and then safely rewarm them back to 37 degrees before coming off the pump.
So now we have fully oxygenated, temperature-controlled blood leaving the oxygenator.
It then passes through a microscopic arterial filter. This is the final safety net. It catches any microscopic air bubbles, stray particulate matter, or microthrombi that formed in the circuit.
And
Finally, this pristine, pressurized blood is returned to the patient's systemic circulation via an arterial cannula that the surgeon has sewn directly into the ascending aorta.
venous cannula, gravity drain to reservoir, active pump, membrane oxygenator and heat exchanger, arterial filter, and back into the aorta. The circuit makes mechanical sense, but biology hates foreign material.
It really does.
If you run 5 liters of patient blood through square meters of plastic tubing and artificial membranes, the body's intrinsic coagulation cascade will trigger instantly. The entire machine would clot solid in 60 seconds.
Which is why profound systemic anticoagulation is the single most critical pharmacological step of the entire procedure. Before the surgeon is even allowed to touch the aorta to place the cannulae, you must administer a massive, paralyzing dose of heparin.
The standard dose is typically 300 to 400 units per kilogram of body weight, right?
Correct.
Let's go down to the molecular level. How does heparin actually stop blood from clotting?
Heparin itself does not break down clots. It is an indirect anticoagulant. It binds to a naturally circulating protein in the patient's plasma called antithrombin III.
Okay, so it needs antithrombin III to work.
When heparin binds, it causes a conformational change in antithrombin III that accelerates its ability to inactivate key clotting factors, specifically thrombin, which is factor 2, and factor ZA by 1,000-fold.
It essentially turbocharges the body's natural off switch for the coagulation cascade.
And because it's a matter of life and death, we don't just give the dose, look at the clock, and guess that it's working. We have to prove it.
We measure the activated clotting time, or ACT. A normal unheparinized ACT is around 100 to 120 seconds.
Before the surgeon initiates bypass and opens the clamps to the machine, you, the anesthesiologist, must verbally confirm that the ACT is greater than 400 to 500 seconds.
And if it's not?
You give more heparin. If you go on pump with an ACT of 250, the oxygenator will thrombose, flow will stop, and the patient will die.
Okay, the ACT is 450. The surgeon opens the clamps, machine takes over. This is where the exams focus heavily on the physiological effects of CPB. What happens to the human body when a plastic machine completely hijacks its circulation?
It is a massive, multi-system, non-physiological insult. The first major immediate effect is hemodilution.
Let's explain why.
Remember, the entire CPB circuit, the tubing, the reservoir, the oxygenator, cannot be filled with air. It must be completely primed with fluid, usually 1 to 2 liters of clear crystalloid solution before it's connected.
When you initiate bypass, the patient's blood instantly mixes with this massive volume of clear prime.
So you are instantly watering down their blood, profoundly. The patient's hematocrit will plummet in seconds. The target hematocrit while on pump is generally allowed to drop to around 21 to 22%.
Why do we tolerate a hematocrit that low? Doesn't that drastically reduce the oxygen-carrying capacity of the blood?
It does reduce oxygen carrying capacity, but it provides a crucial physical benefit. Lowering the hematocrit decreases the physical viscosity of the blood.
To keep it flowing.
Exactly. When the patient is cooled down to 28 degrees Celsius, normal blood becomes thick and sludgy, and microvascular capillary perfusion stops. Diluting the blood keeps it thin enough to actually flow through the chilled capillary beds, ensuring that oxygen at least reaches the tissues, even if there is less oxygen per milliliter of blood.
Okay, the second major physiological effect of the pump.
The inflammatory response. Systemic inflammatory response syndrome, or SIRS. We mentioned that biology hates foreign material. The patient's entire blood volume is suddenly exposed to huge surface areas of artificial, non-endothelial plastic and silicone inside the tubing.
Contact activation.
Exactly. Factor 12 meets the foreign surface, activating the kinin cascade, which generates bradykinin, causing massive systemic vasodilation.
And the complement system too, right?
Simultaneously, complement proteins C3a and C5a act as anaphylatoxins. They trigger neutrophils to degranulate and release reactive oxygen species. They cause profound capillary endothelial leak.
So plasma fluid pours out of the blood vessels and into the tissue spaces.
The patient develops total body edema. Their lungs swell, their brain swells, their gut swells. The machine keeps them alive, but it triggers a full-blown systemic inflammatory storm.
The third major effect is hypothermia. You mentioned the heat exchanger earlier. Cooling the patient is deliberate. Let's explain the math of why we freeze them.
Hypothermia is the ultimate metabolic brake pedal. We cool the patient to aggressively reduce the cerebral metabolic rate of oxygen, or CMRO2, and the global metabolic demand of the organs.
What's the physiological rule of thumb there?
That for every 10 degrees Celsius drop in core body temperature, metabolic oxygen demand decreases by approximately 50%.
Wow.
By cooling the patient from 37 degrees down to 27 degrees, you cut their oxygen requirements in half, offering profound protection to the brain and kidneys against the non-physiological flow states of the bypass pump.
And the fourth major effect, coagulation disturbances. We know they are heparinized, but the pump itself actually damages the physical components of the blood, doesn't it?
It does. The mechanical violence of the pump is unavoidable. The sheer stress of the blood being squeezed by roller pumps or spun by centrifugal cones, combined with the microscopic collision with the oxygenator fibers, causes profound platelet dysfunction.
It physically strips the receptors off the platelets.
Yes. The platelets might still exist in the bloodstream, but they are battered, bruised, and their surface glycoprotein receptors are sheared off. They completely lose their ability to aggregate and form a plug.
And red blood cells.
The pump also physically crushes red blood cells, causing mechanical hemolysis. So even after you reverse the heparin at the end of the surgery, the patient is still at a massive risk of hemorrhage because their surviving platelets simply do not work properly.
I want to ask a fundamental physics question about the pump itself. We are literally pumping blood with a machine. The normal human heart beats. It creates a pulse wave. A bypass machine just delivers a continuous, smooth, flat flow of blood.
Right.
How does the central nervous system react to blood flow that has no pulse?
The physiological implications of non-pulsatile versus pulsatile flow is a classic debate in perfusion science. Machines use non-pulsatile continuous flow because it is mechanically much easier to generate. It simplifies the complex circuit, and continuous flow actually causes slightly less mechanical hemolysis of the red blood cells.
But the human body expects a pulse.
It does. The baroreceptors located in the carotid sinus and the aortic arch do not just sense absolute pressure, they specifically sense the rate of change in pressure, the dPdt of the pulse wave.
So when you switch to the smooth flow,
When you switch to the smooth, flat flow of the bypass machine, the baroreceptors effectively stop firing normally. The brain interprets this lack of pulsatility as a severe hypotensive crisis, even if the absolute pressure is adequate.
it thinks the heart is failing.
Exactly. The sympathetic nervous system ramps up, altering circulating catecholamine levels and causing intense peripheral vasoconstriction, driving up systemic vascular resistance. Furthermore, the kidneys rely on pulsatile flow to maintain normal cortical filtration gradients. Prolonged non-pulsatile flow can significantly alter renal perfusion.
So while the machine is running, the perfusionist is managing the flow rate, usually targeting a cardiac index of 2.2 to 2.4 liters per minute per square meter. What is the anesthesiologist actually doing? You aren't ventilating the lungs anymore.
You are meticulously monitoring the depth of anesthesia. Because the lungs are collapsed, you cannot deliver volatile anesthetic gases through your normal circuit. The perfusionist must administer the volatile agent via a dedicated vaporizer attached directly into the sweet gas of the membrane oxygenator.
And hemodynamics.
You are closely monitoring the mean arterial pressure, or MAP, usually targeting between 50 and 70 millimeters of mercury. You must ensure adequate urine output to confirm renal perfusion. But your most critical conceptual role during this phase is understanding myocardial protection.
Ah, myocardial protection. This is the magic trick. This is how the surgeon completely stops the heart from beating, leaves it starved of blood flow for over an hour, and yet the heart muscle doesn't die. Cardioplegia. Explain the mechanisms how this actually works.
To perform the microscopic, delicate suturing of a 1 millimeter bypass graft, the surgeon needs a perfectly still, entirely bloodless heart. They achieve this by placing a heavy steel clamp across the ascending aorta, the aortic cross clamp. This isolates the heart from the systemic circulation. Immediately after placing the clamp, they inject a solution called cardioplegia directly into the aortic root, which flows down into the coronary arteries.
What is in cardioplegia?
Cardioplegia is essentially a highly concentrated potassium solution, usually mixed with blood and chilled to 4 degrees Celsius.
Why massive doses of potassium?
It alters the resting membrane potential. Normal cardiac myocyte resting membrane potential is around -90 millivolts. By flooding the extracellular space with massive amounts of potassium, you force the resting membrane potential to depolarize to around -50 millivolts.
So you trap it in that state.
At this specific voltage, the fast sodium channels in the cell membrane open once and then immediately become trapped in an inactivated state. They cannot reset.
So the electrical signal is completely blocked.
The heart is instantly arrested in diastole. It goes completely flaccid and still. Because it is no longer performing the massive mechanical work of beating, and because the muscle is freezing cold from the chilled solution, the myocardial oxygen demand drops by over 95%.
Incredible. It's essentially cryosleep for the heart.
This state of profound suspended animation is what allows the heart muscle to survive the 60 to 90 minutes it takes for the surgeon to meticulously sew all the grafts into place while the aorta is clamped.
Time jumps forward. The surgeon has finished the final stitch on the last graft. The bypass plumbing is complete. Now we have the terrifying task of waking the heart back up and transitioning the patient off the machine. Part G, weaning from cardiopulmonary bypass.
This is a very high-yield exam area.
You can't just flip a switch and turn the machine off. What is the preparation checklist before weaning?
Weaning is a highly coordinated, tense dance between the surgeon, the perfusionist, and the anesthesiologist. You must follow a strict sequential checklist. First, rewarming.
So the perfusionist uses the heat exchanger to gradually warm the patient's blood back to 37 degrees Celsius. Why gradually? Why not just blast it with hot water?
Because of the physics of gas solubility, cold fluid holds more dissolved gas than warm fluid. If you rewarm the blood too rapidly, the dissolved oxygen and nitrogen will suddenly come out of solution, forming thousands of microscopic gas bubbles in the blood, massive microemboli that will shower the brain and cause catastrophic strokes. You must rewarm slowly.
Checklist item 2.
Restore ventilation. The lungs have been collapsed and completely immobile for hours. You must systematically manually re-expand them, clear the secretions, and restart the mechanical ventilator. The machine will soon stop oxygenating the blood, so the lungs must be ready to take over instantly.
Checklist item 3. De-airing.
Yes. The surgeon has been sewing inside an open circulatory system. Air has inevitably entered the heart chambers, or the grafts. Before the heart is allowed to start forcefully ejecting blood, the surgeon must meticulously maneuver the heart and vent the chambers to suck out every tiny bubble of trapped air to prevent systemic embolization.
And the final prep step, checking the metabolic status.
You must draw an arterial blood gas. You correct any severe acid-base disturbances. But crucially, you must look at the serum potassium level.
Oh, because of the cardioplegia.
Remember, you just spent the last hour intentionally flooding the heart with massive doses of potassium. When the cross clamp comes off, that potassium washes into the systemic circulation,
Which will cause lethal arrhythmias.
Exactly. You often need to administer a large dose of a loop diuretic, like furosemide, to force the kidneys to aggressively excrete that massive potassium load before the heart can be expected to establish a normal, stable rhythm.
Okay, the checklist is complete. The patient is warm, breathing, de-aired, and the potassium is normal. How does the actual transition of workload happen? How do we physically give the job of pumping blood back to the heart?
It relies on manipulating physics. The perfusionist slowly, incrementally, occludes the venous drainage line that was siphoning blood out of the patient. This forces venous return, which was previously going into the machine's reservoir, to instead fill the patient's right atrium and right ventricle.
You are returning the preload.
Yes. As the right heart fills, the myocardial fibers physically stretch. According to the Frank-Starling law of the heart, this physical stretch increases the force of contraction. The right heart begins to eject blood through the newly reinflated lungs, which then fills the left ventricle. The left ventricle stretches, and it begins to contract.
It's like retensioning a heavy industrial spring. You slowly apply the load, and the spring pushes back.
And during this exact moment, the anesthesiologist's eyes are glued to the transesophageal echocardiogram.
Intensely. You are not looking at the surgical field, you are looking at the screen. You are visually assessing left ventricular end diastolic volume, making sure it is filling adequately, and you are assessing contractility.
If the heart is sluggish and struggling from the immense ischemic insult of the bypass run, you do not force it to work alone.
You step in with pharmacology.
Exactly. You may need to start inotropic support. If you need pure, forceful squeezing power and blood pressure, you might start an epinephrine infusion, which heavily stimulates beta-1 receptors to increase contractility and alpha-1 receptors to maintain vascular tone.
What if the right heart is failing?
If the right heart is failing due to pulmonary hypertension from the inflammatory response, you might choose milrinone.
A phosphodiesterase 3 inhibitor.
Yes, milrinone is an inodilator. It increases contractility while simultaneously dilating the pulmonary vasculature, making it easier for the struggling right heart to push blood through the lungs.
But it dilates everything, right?
However, it also dilates the systemic vessels, so you often have to run a second infusion of norepinephrine just to counteract the vasodilation and maintain a perfusing blood pressure.
And what if the heart is squeezing fine, but the electrical system is damaged? The cold cardioplegia often stuns the AV node.
If the heart is in a profound bradycardia or complete heart block, the surgeon will sew temporary epicardial pacing wires directly onto the surface of the right atrium and right ventricle.
And you connect those to a box.
You connect these wires to an external pacemaker box and artificially set the heart rate, usually to around 90 beats per minute, to guarantee adequate cardiac output. Once the heart is generating adequate stroke volume and blood pressure on its own, the perfusionist completely clamps the arterial return line, turns off the main pump, and the patient is officially separated from cardiopulmonary bypass.
The machine is off, the heart is beating, the plumbing works, the surgery is effectively over, but the anesthesiologist's job isn't even close to being done. We move to Part H, postoperative management.
First, we must reverse the systemic heparinization. The patient has a massive ACT and will bleed to death if we don't fix it. We administer protamine sulfate.
Let's talk about the pharmacology of protamine, because examiners will ask how it works and what its dangers are. Where does it even come from?
Protamine is a highly alkaline, positively charged polycationic protein originally extracted from salmon sperm.
Salmon sperm, right.
Heparin is a highly acidic, negatively charged polyanionic molecule. When they meet in the bloodstream, they undergo a simple acid-base ionic interaction, instantly binding together to form an inactive, stable salt complex that is then cleared by the reticuloendothelial system.
It sounds simple. Why is giving it considered one of the most dangerous moments of the procedure?
Because protamine administration can cause catastrophic hemodynamic collapse. If you push the protamine too quickly, it triggers a massive release of histamine, causing profound systemic vasodilation and a crash in blood pressure.
Are there other reactions?
Even more terrifying, in some patients, it triggers an anaphylactoid reaction that causes massive release of thromboxane A2.
Thromboxane A2 causes extreme pulmonary vasoconstriction.
Exactly. The pulmonary artery pressures instantly skyrocket to systemic levels. The right ventricle, which is thin-walled and not designed to push against high resistance, instantly acutely dilates and fails. The heart stops.
So how do you avoid that?
To prevent this, protamine must be administered incredibly slowly, often over 10 to 15 minutes, while you watch the pulmonary artery pressures on your monitor like a hawk.
Once reversed and stable, the sternum is wired shut, and the patient is transferred to the cardiac ICU. You switch over the monitors, connect the ICU ventilator, establish hemodynamic targets, and manage their pain. But for the exams, you must be prepared to diagnose and treat post-CABG complications.
The big four complications are myocardial dysfunction, bleeding, arrhythmias, and neurological deficits.
Let's run through them.
Myocardial dysfunction, often called low cardiac output syndrome, is very common. The heart is simply stunned from the hour it spent paralyzed and cold on the bypass machine. It needs inotropic support and time to recover.
And bleeding.
Bleeding is the second major issue, primarily owing to the severe platelet dysfunction and depletion of coagulation factors caused by the mechanical shear stress of the bypass pump we discussed earlier.
Arrhythmias are the third.
Particularly atrial fibrillation. It is incredibly common post-op. The right atrium was physically cut open to insert the massive venous cannula. The tissues are inflamed from SIRS, and the atrium is stretched from fluid shifts. This creates perfect re-entry circuits for AFib.
And the fourth, the most devastating, neurological complications, ranging from subtle, transient cognitive decline to massive, devastating strokes. Why do strokes happen?
Almost entirely due to emboli. When the surgeon applies the heavy steel cross clamp to a calcified aorta, or when they punch holes in the aorta to sew the grafts, microscopic chunks of calcium and atheroma break off and travel straight up the carotid arteries to the brain. The bypass machine itself also generates microbubbles of air and plastic microparticles that contribute to neurological injury.
Now, I want to present a classic clinical scenario that tests pure physiological understanding. This is exactly the kind of trap an examiner will set in Aviva.
Let's hear.
You are managing the patient in the ICU 2 hours after surgery. The blood pressure starts dropping, the cardiac index is falling, the heart is failing. But how do you definitively tell the difference between a heart that is simply too stunned and weak to squeeze classic myocardial dysfunction and a heart that is being physically squished from the outside by a massive blood clot, which would be cardiac tamponade?
This is a superb test of hemodynamics. Cardiac tamponade is extrinsic compression. Blood or clots accumulate inside the tough, rigid pericardial sac that surrounds the heart. As the volume of blood outside the heart increases, the pressure inside the sac rises. It eventually begins to equal the pressure inside the heart chambers during diastole.
Equalization of pressures.
Exactly. When the external pressure equals the internal filling pressure, the heart physically cannot expand to accept venous return. If it cannot fill, it has nothing to pump. Stroke volume plummets, and severe cardiogenic shock ensues.
How does that look on your invasive monitors compared to just a weak, stunned heart?
If the heart is just weak and failing, your central venous pressure might be high because blood is backing up, but your pulmonary artery pressures will be even higher and your left-sided filling pressures will be different again. You maintain a gradient.
But with tamponade?
With tamponade, you see the classic equalization of diastolic pressures across all chambers. The central venous pressure, the pulmonary artery diastolic pressure, and the PA occlusion pressure all converge to the exact same elevated number, say 20 millimeters of mercury. The entire heart is uniformly crushed.
But examiners also want to see your clinical situational awareness. They will give you a trap regarding the chest tubes.
Yes, the trap is the sudden cessation of bleeding. Let's say the patient was bleeding heavily into their chest tubes 200 milliliters an hour. Suddenly, you look over and the chest tubes have completely stopped draining. A few minutes later, the blood pressure drops and the CVP rises.
An inexperienced resident might think, great, the bleeding finally stopped.
An expert realizes that the bleeding didn't stop. A massive clot has formed inside the silicone chest tube, blocking it completely. All that ongoing bleeding is now trapped inside the chest, backing up into the pericardial space, and rapidly crushing the heart. The chest tube suddenly stopped draining is the ultimate red flag for impending tamponade.
Brilliant. Okay, we have covered standard on-pump CABG exhaustively. We must pivot to part 1, off-pump CABG, or OPCP. We talked about the analogy earlier trying to replace the spark plugs while the car engine is running at 80 miles an hour. Let's delve into the actual practical anesthetic considerations of beating heart surgery. First of all, how does the surgeon even access the tiny vessels on the back of a heart that is beating 70 times a minute?
They use specialized mechanical devices. They use a tissue stabilizer, which looks like a tiny metal arm with suction cups. It uses negative pressure to physically grip the myocardium immediately surrounding the target artery. It pins that tiny 1-inch square of tissue completely still, while the rest of the left ventricle continues to beat wildly around it.
But the coronary arteries aren't all conveniently located on the front of the heart. What about grafting the posterior descending artery, or the circumflex, which are literally underneath and behind the heart?
This is where the anesthetic nightmare begins. To access those posterior vessels, the surgeon must use deep pericardial traction sutures or a mechanical heart positioner to physically lift the massive, heavy heart entirely out of the pericardial well and rotate it vertically up into the air.
I cannot imagine the cardiovascular system appreciates the heart being hoisted out of the chest. What happens to the hemodynamics?
It is absolute chaos. First, verticalizing the heart causes extreme compression of the right ventricular outflow tract as the right ventricle is smashed against the edge of the pericardium. Second, and more importantly, lifting the apex of the heart drastically kinks the superior and inferior vena cava.
You are physically bending the pipes that return blood to the heart.
Yes. Venous return plummets instantly. If you look at the Starling curve, the heart moves violently down and to the left. Preload drops to near zero, stroke volume drops precipitously, and the systemic blood pressure absolutely tanks.
So what are the anesthesiologist's counter moves? The surgeon needs 10 minutes to sew the graft. You can't just let the patient sit there with a mean arterial pressure of 30.
You have to aggressively intervene before the surgeon lifts the heart. First, manipulate physics with positioning. You place the operating table in steep Trendelenburg head tilted drastically down, legs pointing up. This uses gravity to increase venous hydrostatic pressure, forcing blood from the lower body to flow uphill and overcome the physical kinking of the vena cava.
Second move.
Aggressive volume loading. You fill the tank, you give crystalloid or colloid boluses to artificially inflate the intravascular volume and force preload into the right atrium.
Third move.
Vasoactive pharmacology. You run continuous infusions of potent vasoconstrictors like norepinephrine or pure alpha agonists like phenylephrine. You squeeze the peripheral arterial system to artificially maintain the mean arterial pressure and ensure coronary and cerebral perfusion while the heart's intrinsic output is temporarily paralyzed by the physical displacement.
And when they drop the heart back?
Once the graft is sewn and the surgeon drops the heart back into its anatomical position, venous return surges back, and you must instantly turn off your vasopressors and level the bed, or the patient will shoot into severe stroke-inducing hypertension.
It sounds like a terrifying roller coaster. So if OPC cave is this hemodynamically unstable, why do it? We established that avoiding the bypass machine prevents the massive inflammatory SIRS response, avoids hemodilution, and avoids clamping the aorta, which causes strokes. Given all those benefits, isn't OPC cave always better? Why don't we do every single case off pump?
Because the long-term clinical data does not support doing it for everyone, you must reference the major trials here, like the RWMA trial randomized on-off bypass. The data shows a very specific trade-off.
Break down the pros and cons based on the data.
OPC cave is highly beneficial for very specific high-risk populations. If a patient has severe chronic kidney disease and cannot tolerate the hemodilution and non-pulsatile flow of the pump, OPC protects their kidneys. If a patient has a heavily calcified porcelain aorta, where applying a steel cross clamp would shatter the calcium and cause a massive stroke, OPC is absolutely life-saving. It also generally reduces the need for postoperative blood transfusions.
But what are the drawbacks? Why did the RWMA trial give everyone pause?
The drawbacks are surgical, not physiological. OPCA has a significantly higher rate of incomplete revascularization. A surgeon might plan to do 3 grafts, but because the heart is beating and the posterior vessel is too difficult to access safely without crashing the blood pressure, they only complete 2 grafts. The patient leaves the OR with untreated ischemia.
And the quality of the grafts themselves.
That is the most critical issue. Sewing a 1mm artery onto a target that is moving and bleeding is astronomically difficult, even for world-class surgeons. The anastomoses are simply not as technically perfect as they are when sewn on a completely arrested, still dry heart on the bypass machine.
So they fail more often.
Consequently, OPCAB patients have a statistically higher rate of graft failure. Their grafts close up and they have a higher rate of needing repeat surgery or rescue stents 5 to 10 years down the line.
It's the ultimate trade-off. Short-term physiological protection from the pump versus long-term mechanical durability of the plumbing. Okay, we have traversed the entire landscape. We have reached the final segment, Part J, our exam integration. Let's tie a neat bow on this for our Gujarat University resident. First, a rapid-fire comparative summary. CABG versus OPCAB.
On-pump CABG triggers massive systemic inflammatory response syndrome, requires profound hemodilution and extreme anticoagulation, causes significant postoperative platelet dysfunction. However, it provides a perfectly still, bloodless operative field resulting in superior, long-lasting graft patency.
And off-pump.
Off-pump CABG, or OPC-HAB, avoids SIRS, avoids massive hemodilution, and avoids the aortic cross-clamp. Spares renal and neurological function in high-risk patients. However, it causes profound, terrifying intraoperative hemodynamic instability during heart positioning and results in slightly lower long-term graft patency due to extreme technical difficulty.
Excellent. Now, what are the common Viva traps? When you sit across from an examiner, where do students consistently lose marks?
Trap number 1. A superficial understanding of CTB physiology. Students often forget that initiating bypass isn't just turning on mechanical pump. It's instantly diluting the patient's entire blood volume with 1 to 2 liters of clear fluid. You must explicitly state that the hematocrit drops massively and intelligently explain how you balance the decrease in oxygen carrying capacity against the benefit of decreased viscosity during hypothermia.
Trap number 2.
Ignoring myocardial oxygen balance during the induction phase. If an examiner asks how you induce a severe CABG patient and you casually say propofol and suxamethonium, you will fail the station. You must explicitly state your overarching goal is to prevent tachycardia and maintain diastolic filling time, justifying your use of high-dose cardiostable opioids like fentanyl.
And trap number 3.
In the advanced monitoring station, relying on the pulmonary artery catheter. If asked how to detect intraoperative ischemia, you must not say a sudden rise in the PA occlusion pressure. You must confidently state transesophageal echocardiography to detect new regional wall motion abnormalities, and then you must prove you know why by explaining the ischemic cascade, noting that wall motion fails long before the pressures ever change.
That is absolute gold. Now for the written papers, the 20-mark long essays. How should they present this massive volume of information physically on the page to secure maximum marks?
You must use clear, well-labeled diagrams. An examiner marking hundreds of dense text papers loves a candidate who can visually synthesize complex systems. Draw out the basic cardiopulmonary bypass circuit. Visually link the venous cannula, the gravity reservoir, the main roller pump, the membrane oxygenator with its heat exchanger, the arterial filter, and the aortic return cannula.
What else did they draw?
Draw a simple anatomical schematic of the coronary circulation, show the left main splitting into the LAD and the circumflex, and trace the right coronary artery, marking where the classic blockages occur and where the LIMA is grafted. Finally, draw a logical flowchart of your hemodynamic management steps during OPCA displacement. Visually show the physical kinking of the vena cava leading to a drop in venous return, triggering your specific interventions of steep Trendelenburg, fluid boluses, and vasopressors. Visuals demonstrate profound, organized understanding.
All right, we are at the finish line. Let's run through a high-yield bullet point recap. These are the absolute most critical takeaways from this entire deep dive. Number 1. Ischemic heart disease is a rigid supply and demand mismatch, frequently complicated by the dynamic reactive stenosis of eccentric plaques.
Number 2. The left internal mammary artery, the LIMA, is the superior bypass conduit because its endothelium actively secretes nitric oxide, rendering it highly resistant to atherosclerosis.
Number 3. Functional capacity is the ultimate preoperative assessment tool. For MEs, the ability to climb a flight of stairs is the critical survival threshold.
Number 4. A preoperative baseline ECG is absolutely required to provide context for identifying new intraoperative ischemic changes.
Number 5. TE is vastly superior to the PACture for early ischemia detection because regional wall motion abnormalities occur at step 3 of the ischemic cascade, preceding any ECG or hemodynamic pressure changes.
Number 6. Anesthetic induction must avoid tachycardia at all costs to preserve the vital diastolic coronary filling time.
Number 7. Volatile anesthetics provide crucial ischemic preconditioning, protecting the mitochondria from calcium overload at a cellular level.
Number 8. Systemic anticoagulation is paramount. The target ACT before initiating bypass must be greater than 400 to 500 seconds to prevent fatal oxygenator thrombosis.
Number 9. Cardiopulmonary bypass triggers a massive physiological insult characterized by SIRS, hemodilution, hypothermia, and mechanically induced platelet dysfunction.
Number 10. Weaning from the pump is a deliberate sequence requiring rewarming, restoration of ventilation, meticulous de-airing, and aggressively correcting cardioplegia-induced hyperkalemia.
Number 11. Cardiac tamponade in the ICU is characterized by the fatal equalization of diastolic filling pressures and the classic trap of a sudden cessation of chest tube output due to clotting.
Number 12. Off-pump CABG avoids the inflammatory storm of the pump but causes massive predictable hemodynamic crashes due to physical heart displacement, requiring aggressive preload and afterload management with positioning and vasopressors.
That is a phenomenal, comprehensive summary of the essential physiology. Now, for the student sitting in that exam hall writing that final 20-mark essay, here is a model conclusion paragraph.
You can synthesize everything we've discussed by writing this. In conclusion, the anesthetic management of coronary artery bypass grafting is a delicate, high-stakes orchestration of maintaining myocardial oxygen supply and demand balance. It requires precision hemodynamic monitoring to detect early ischemia and an absolute mastery of the profound physiological alterations induced by cardiopulmonary bypass, ensuring seamless, hemodynamically stable transitions from the precarious pre-bypass state to robust post-bypass recovery.
I love that phrasing, a delicate orchestration. It perfectly shows the examiner that you respect the immense complexity of the procedure. Now, before we sign off, I want to leave you with a final provocative thought, something to mull over as you continue studying. We talked extensively about the massive systemic insult to the bypass machine and the mechanical difficulties of OPCA. But the field of cardiac surgery is advancing rapidly toward robotic total endoscopic TDBG or TCAB.
The ultimate, minimally invasive approach.
Exactly. It requires only tiny pencil-sized quarts in the chest. But to give the robotic arms room to work inside the closed chest cavity, the anesthesiologist must deliberately collapse the left lung, entirely initiating complex one-lung ventilation, and then insufflate the chest cavity with carbon dioxide under pressure to create a working space, all while the robot sutures the beating heart.
It completely changes the physiological battlefield.
So the question to ponder is this. As TACAB technology evolves and becomes the standard, will the future of cardiac anesthesia move away from managing the massive whole-body systemic inflammation of the bypass machine and evolve entirely toward managing the intense, highly localized physiology of a pressurized one-lung ventilated chest containing a beating, displaced heart? It feels like we're trading a whole-body physiological war for a highly complex, localized hemodynamic puzzle.
It's a fascinating paradigm shift. The specific clinical challenges will completely transform, but the underlying requirement for a profound mechanistic understanding of cardiopulmonary physiology remains exactly the same.
Absolutely. The tools change, but the physics of the heart remain. Well, to our listener at Gujarat University, we wish you the absolute best of luck on your MD anesthesiology exams. You have the knowledge, you understand the deep physiological why behind every action. Now go execute and write those perfect answers. Stay curious, trust your preparation, and keep diving deep.